Thank you for joining today's NCCN webinar for patients breast cancer screening. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon. If you ordered a free book when you registered for this webinar, you should be receiving it shortly. The NCCN webinars for patients complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Therese Beavers. Dr. Beavers is Medical Director of the Cancer Prevention Center at the University of Texas MD Anderson Cancer Center. Following Dr. Beavers, we will hear from Jennifer Ivanovich. Jen is Associate Professor and Genetic Counselor at Indiana University, Melvin and Bren Simon Comprehensive Cancer Center. Our third presenter today is Sue Freeman, Executive Director and founder of FORCE, Facing Our Risk of Cancer Empowered. Now I will turn it over to Dr. Beavers.
Thank you. Thank you all for signing up for this rescheduled webinar. I'm the presenter that got ill, so I'm very grateful that you were willing to sign up again. Unfortunately, I still have allergies hanging around, and hopefully it doesn't get the best of my speaking. So, a note about sex and gender. Breast cancer can develop in both men and women, but occurs obviously more frequently in persons assigned female at birth. This particular webinar will cover screening recommendations for those assigned female at birth who are at average risk of developing breast cancer. We will not talk about individuals at increased risk, although the guidelines do spell that out. The terms female, woman, women will be used to refer to the sex assigned at birth. Transgender individuals should consult with their primary care physician to determine when or whether screening would be appropriate. And those assigned male at birth, they should not undergo a regular mammogram. However, if they develop breast symptoms, they should seek evaluation. So breast cancer is the most commonly diagnosed cancer in women worldwide. It's the second leading cause of cancer death in American women. It's the leading cause of premature cancer mortality, both in total person years of life lost and average years of life lost. Mammography is the only screening test for breast cancer that has been shown in randomized controlled trials to reduce a woman's chance of dying from breast cancer. So there are a number of organizations that make screening recommendations. The most notable ones are the U.S. Preventive Services Task Force, the American Cancer Society, and NCCN. So they have different ages as to when to start screening and the frequency of screening. The task force says start at age 40 and do it every 2 years. Note, This is a draft recommendation. It is likely to be finalized this year. ACS, opportunity to begin screening at ages 40 to 44, but regular screening should start at age 45, annually between ages 40 to 54, and every other year starting at age 55, but still can do every year based on patient preference. NCCN says start at age 40 and do it every year. So this is the actual screening guideline. We break it into average and increased risk. We're not going to talk about this. We will focus on this section. So we recommend breast awareness beginning at age 25. We no longer recommend breast self-exam. Rather, be aware. If you notice a change, seek evaluation. Clinical encounter every 1 to 3 years between ages 25 to 39, and every year beginning at age 40. And then annual mammogram with tomosynthesis beginning at age 40. So what is tomosynthesis? The X-ray tube moves in an arc across the breast. It acquires a series of low-dose images from different angles, and these projection images are reconstructed into 1 millimeter slices. The reconstructed slices eliminate tissue superimposition. It leads to improved visibility of mass lesions. It also decreases recall rates and biopsy rates. So you can see we didn't see it in the first 2 slices. All of a sudden, the cancer is uncovered in the 3rd slice. So when should we stop screening? Well, the upper age limit is not established for NCCN. We recommend consideration of severe comorbid conditions that limit life expectancy. So say someone has metastatic pancreatic cancer. They're not going to die from breast cancer. They're going to die from the pancreatic cancer. So we don't need to look for breast cancer. And then also, will they undergo treatment? Some individuals don't wish to undergo treatment. Some are not treatment candidates, either based on comorbid conditions or just simply age. So, key information for informed decision about breast cancer screening. You want to know what is a woman's risk of developing breast cancer, both the near term and long term. What are the limits of risk prediction? Is she a candidate for medications that can reduce her risk? What are the benefits of screening? And what are the harms and limitations of screening? So very briefly, the benefits. We see fewer individuals die from breast cancer by getting screened, so decreased mortality. And so there is an increase in life years. More early stage breast cancers are identified, and often less extensive treatment is needed. The woman may not need a full axillary lymph node dissection, just a sampling, and that reduces the risk of lymphedema. She may not need chemotherapy or radiation therapy. And it also identifies precursor lesions that can be managed to reduce her risk of developing breast cancer. So what are the harms? Well, this page lists the 4 common harms that are cited. One is false negatives. That's where the screening test is negative, but a cancer actually is present. Fortunately, that is very rare. False positives. Unfortunately, this is more common, but the good news is 80% of callbacks and workups are benign. Radiation exposure. Actually, it is negligible. It is the lowest of all the ionizing radiation tests that are done, chest X-ray and CT scans, etc. Screening mammogram has the lowest radiation exposure. To put it into context, it's about equivalent to what a woman would experience on a round trip flight from Houston to Paris and back. So pretty negligible. So I like to tell my patients, if you'll go to Paris, then get your mammogram. And then overdiagnosis. This is diagnosing a cancer that is so indolent that it would never become clinically apparent in that person's lifetime. So that results in us treating an individual that really doesn't need treatment because it never would become a problem in their lifetime, and the associated psychological distress. Often it is assumed that if you don't screen, that there are no harms. But in fact, there are harms of not screening. There's a higher mortality. More women will die from breast cancer by not getting screened. They'll be diagnosed with more advanced cancers that require more intensive treatments. And guess what? There still will be false positives. Women will present with a palpable mass that after workup is determined to be benign. So we don't eliminate false positives by not screening. So as I mentioned, the U.S. Preventive Services Task Force, while they're lowering their screening age from 50 to 40, they still are recommending that women get their mammogram biennially or every other year. And their rationale is, well, you get 81% of the benefit of annual screening, but you cut the number of false positives in half. They're very harms adverse, very false positive adverse. So there are no trials that have compared annual screening with biennial screening. The screening interval is influenced by estimates of the rate of a tumor's growth and interval cancer development. So cancers that develop in between this screening interval and this screening interval. Screening intervals have been recommended based on trade-offs between estimated mortality rates and false positive rates. The opportunity to prevent a breast cancer seems highly valued by most American women, as indicated by published literature and screening rates. Most express or demonstrate willingness to tolerate the process of resolving abnormal findings, including additional procedures regarded as harms. So what about dense breast? How do you know if you have dense breast? Often you will get a letter that says, if you have dense breast, you may benefit from supplemental screening, but it doesn't tell you if you have dense breast. In the United States, there is very specific nomenclature. Dense breasts are those that are cited as extremely dense or heterogeneously dense, whereas non-dense breasts are scattered fibroglandular densities and fatty replaced. That scattered fibroglandular densities confuses a lot of people because of the word densities. In the United States, the report is required in the opening to state what is the level of density. So women with dense breasts may benefit from supplemental screening with ultrasound or MRI. They should be counseled on the risk and benefits of supplemental screening. Both tests can increase the cancer detection rate in women with dense breast tissue, but it increases false positives, recalls, benign biopsies. So here is data from a study that was done looking at supplemental ultrasound. What was seen was the supplemental yield of cancers per 1,000 women was 4.2%. Pretty small. False positives, however, were increased about 2.5-fold. So annual screening beginning at age 40 achieves the greatest benefit. Screening should be tailored to a woman's risk of developing breast cancer. And now I'm going to turn it over to my colleague, Jennifer.
Thank you, Dr. Beavers, and welcome everyone. It was really encouraging to see we have colleagues from all over the world. And so it's exciting to be a part of a group that's coming together for a shared purpose. I work as a cancer genetic counselor in Indiana, and I've been asked specifically to talk about genetic counseling as well as genetic testing. So in the United States, genetic counselors participate in a master's degree program. There are currently 56 accredited programs in the United States and 4 in Canada. Genetic counselors will undergo a national board certification as well as a state license. And we have over 6,000 genetic counselors in the United States. And for those colleagues around the world, that's certainly not the case. And I think calls for the need of how do we in the United States try to support our colleagues around the world. Many genetic counselors work in a variety of different specialties. I focus on cancer genetics, working in families who have a family history or a personal history of cancer. But you may meet or work with a genetic counselor in a wide variety of disciplines. So if we just simply try to define what are we trying to achieve with genetic counseling, and in particular, cancer genetic counseling, it's identifying, educating, and facilitating the care of individuals who have an increased risk for cancer. I know this seminar is focused on women who have an average calculated risk, but genetic counseling may uncover that someone's actually at increased risk for breast and other types of cancers. And not only trying to conduct that assessment for the family, but also attend to the psychosocial issues that are associated with hereditary disease. And I'm thrilled that Sue Friedman from the FORCE group is here because that's a large part of what they do. So there's a number of risk factors that we all know can increase risk for breast cancer. Age, gender, and family history are 3 of the biggest risk factors. Certainly thinking about a person's personal history, if they've had a radiation exposure, for example, for treatment for lymphoma as a child, and then a wide variety of other risk factors. And in cancer genetic counseling, we are typically focused on family history and personal history. Thinking about your own family, I would encourage you to document your family history. And when we are seeing someone based on their family history of cancer, we're looking for a variety of features within the family history to help guide, do we think that that family might have an increased risk for breast and other cancers? You can see, for example, having more than one type of cancer for a given individual, or having an unusual or less common presentation, such as male breast cancer. But we're also looking for a variety of other factors, such as the age at diagnosis. And do they have, for example, unusual skin findings that may point to a particular diagnostic syndrome for us? So this is a family pedigree, and if you're not used to looking at pedigrees all day like I am, this is a woman who's 30 years of age. She has a sister who was diagnosed with breast cancer at 34. This is her maternal side of the family and her paternal side of the family. And part of the reason why we use a pedigree structure is it allows us to easily see the cancer diagnoses in the family, as well as get a sense of the family structure. And so you can see this dominant pattern of inheritance, 3-generation. We have multiple early onsets of cancer diagnosis. So in a family like this, we could not say that this woman is at average risk for breast cancer until we do more to evaluate the family. And why would we want to know that? Why would families want to know if they have an increased risk for breast or other cancers? Oftentimes it's helpful to use in their own medical management. We've described, Dr. Beavers has described the breast surveillance for women at average risk, but an increased risk may incorporate additional modalities or starting at even younger ages based upon their risk. Certainly for women who are diagnosed with a breast cancer, it may aid in their medical decision-making or surgical interventions. And then often, and we'll talk a little bit about both tumor and inherited genetic testing, that we could identify targeted therapies in the care of that person. And for many people, thinking not only about themselves, but the practice of genetics is thinking about that family unit. And so are there other family members who may have an increased risk and are not aware of that? In working with your breast radiology team or your primary care team, they may be asking you some questions about your personal and family history. And there are a wide variety of risk models that are available to calculate breast cancer risk. One of the common ones that are used in the primary care setting is referred to as the Gale model or the breast cancer risk assessment tool. And if you look at the features that they're looking at for this particular model, it's focused on not only that woman's age, but a variety of hormonal factors, such as when she started menarche, age at first live birth, and then very limited family history information, family members with breast cancer. In contrast, the Tyrer-Cuzick model incorporates both hormonal factors as well as more detailed family history. And it's important when this model is being used by a provider that they're not just obtaining information about the affected individuals in the family, but understanding the family size and how many women and men in the family are unaffected will impact the calculated risk. These models are both available online if you're interested in calculating your own risk. So that was just a little bit about genetic counseling, and let me switch gears to thinking about genetic testing. And I'm going to put that into two broad categories. There's what I focus on, and a lot of genetic counselors focus on, is the inherited, or what we call germline analysis. This is looking at our inherited genetic makeup to see if we can identify an etiology for that family's cancer history or that person's individual diagnosis of cancer. What's becoming far more common is what we call tumor analysis or somatic analysis, where we're trying to distinguish the genetic architecture or infrastructure of that particular tumor and see how that tumor might be different than 100 other tumors of the same histology. And the reason why we do that is really focused on targeted therapies. Is there something that we can target in that analysis as a treatment for that tumor? In doing this type of analysis, it may suggest the possibility of an inherited factor. It may give us a clue that there is something inherited in the family. There are many different types of genetic tests, and you could come across this from throughout the lifespan that genetic testing is being used. You can have tests where it might just be focused on a single gene. If we know in a particular family they have a particular cancer predisposition syndrome, we could then target that gene in testing at-risk family members. What's typically used in the cancer genetic setting, at least in the United States, is what I would call panel analysis, where that provider picks a particular panel, and it might be a small number of genes, or it may be a broad panel. And they're conducting both sequencing, where they're looking at as many letters of the instructions that they can that make up that DNA sequence, but also looking for changes that we refer to as deletions and duplications, which can also lead to disease risk. Outside of the cancer setting, for example, children who might have developmental delay or might be born with a birth defect, we're using whole exome sequencing and whole genome sequencing. These are much broader tests that can look throughout the entire genome, made up of over 22,000 genes, rather than just looking at 130 genes. And it won't be long in the inherited setting where we're using whole exome or whole genome sequencing for families that have a family history of cancer. So where we often see misinterpretation of genetic test results is we have to consider two factors. One is, what information did we know going into the genetic testing, and what were the test results? So if we were to start with this person who's 30 years of age and has not had a cancer, if we were to start the family genetic testing with her, we don't know by starting with her what has caused this family history. We don't know in this family, do they have an identifiable mutation? So in the most informative approach, whenever you can, you would start with an affected person first. And if you identify a mutation or what we call a pathogenic variant, that gives you enormously important information and can help guide that individual's medical care, the care of their children and other family members. I think what we also find is and spend a lot of time working with families is trying to explain the complexity of the genetic testing itself and the possible test results. If you think about when we're doing genetic testing, we're looking at that person's DNA sequencing and comparing it to what we've referred to as a reference sequence, what we think that sequence should be. And what has been defined are 5 possible results for every gene. And they're either showing the similarity or the difference that they see between that person's gene sequence and the reference sequence. I've been talking about families that have a pathogenic variant or a mutation where they have an identifiable alteration or variant in that gene, which we know disrupts gene function and is the basis for the cancer risk in that family. And we use that to guide medical surveillance. And so having a mutation in certain genes would elevate the risk for breast cancer depending upon the gene, and that would alter screening recommendations beyond average risk screening recommendations. There are families who have testing where we don't find the mutation, and we would say they have a negative result or they have just benign or naturally occurring variants. In this case, we haven't found at the gene level what might have caused that family history. So we have kind of black and white results, if you will. And then, of course, in medicine, there's always gray. And we call our gray a variant of unknown significance, where that person's DNA sequence, there's a variation that's different than the reference sequence, but we don't know if that variation disrupts how that gene works. And thus we can't use it in planning medical care or testing at-risk family members. There's a couple intermediary results, but again, on this spectrum, end of the spectrum, we're going to act upon this result because we found a change that disrupts gene function. And on this end of the spectrum, we did not. And so how we use genetic testing is dependent upon the result. And again, what we know going into the evaluation. Has an affected family member had testing, and do we know the cause of the inherited cancer risk in that family before doing testing? So that was a quick primer on genetic counseling and genetic testing. And it's my privilege now to introduce Sue Friedman, who's the Executive Director and founder of FORCE.
Hi, everyone. Thank you for that introduction and those great presentations. It's such an honor to be here to speak about a topic I'm really passionate about, and that is informed decision-making about risk management, whether you're average risk or high risk. I am personally a 27-year breast cancer survivor. I was diagnosed at age 33. And it turned out I did have an inherited mutation in my BRCA2 gene, but I didn't know that going into it. And for me, one of the things that prompted, I was very fortunate to have my breast cancer found on a mammogram at age 33. And one of the things that I realized early on was that nobody ever showed me how to look at my breast. Nobody talked to me about breast awareness. And at the time that I was diagnosed with breast cancer, I was a practicing veterinarian. And, you know, go back to about age 29 when I first started practicing, I realized that, you know, no doctor had ever examined my breasts. And as a veterinarian, I do deep palpations, or I did, of dogs and cats looking for masses. And I did one of my own breast and found a mass. So that is breast awareness, but nobody ever talked to me about it. That mass was benign, but it was the reason I started getting mammograms at a young age and then found out that I had an inherited mutation. So I'm just one story. And, you know, what my goal for my slides and this talk is to kind of give you guys, kind of pulling it all together and help give you guys information to help you make your own decision. Or if you're an advocate or a healthcare professional, help your patients make decisions about breast screening. So just a little bit about FORCE. We're a national nonprofit organization focused on hereditary cancer risk and people with inherited mutations that increase the risk for cancers, including breast cancer. But a lot of people, like myself, go into this whole risk management issue not knowing they are at high risk. It turns out that my mutation came from my father's side of the family. We had a very small family. So back to that idea of family structure and how genetic counselors approach you know, risk assessment and looking at that family structure, because sometimes mutations can get hidden inside families and you don't know you're at high risk. And that's what happened with me. And I was very fortunate to be proactive with my health. So that's FORCE. And by the way, I do have some QR codes. Feel free to do screen captures. That will take you directly to the FORCE website. And I have a few other QR codes throughout the presentation. So going back to the slide that Dr. Beavers presented on screening mammography and recommendations for average risk women, you can see they're different. I mean, they're similar, but there are differences here. So which guidelines do you follow? And I think many people end up following the guidelines that their doctor recommends. But within that, there's a lot of room for your own personal preference and certainly your family history and those other factors that were presented by Dr. Beavers. These are just two different articles focusing on some research that was done. And I'm not going to go over the entire articles. I just want to point out the headlines because they seem contradictory. The one says regular screening mammograms significantly reduce breast cancer death. And, the one on the other side says mammograms more likely to cause unneeded treatment than to save lives. So, they were different studies. They're being, researched at different times. They come to different conclusions, but it can leave up, your consumers and women confused about what do I do with this information? How do I decide? And, on the left-hand side are some benefits of mammogram screening. And then on the right side, there are harms. And how do we balance this out? And that's not always easy because each of us has different tolerances for risk and uncertainty, and also tolerances for going through things like, additional biopsies that may or may not show that there's cancer there. And so how do you weigh that? And I don't have a set answer. For me, I found a lump. I wanted it biopsied. It was benign. But I was so fortunate because that's when I started getting mammograms right after that. So that, I guess, false positive of feeling a lump and then getting it biopsied led me down a road of getting more mammograms and a diagnosis at age 33. So, in my case, my preference was this idea of erring on the side of finding something rather than potentially missing something. But not everybody agrees with that. And, if you're someone that has breasts that are difficult to image, that have a lot of lumps in it, over time, you can just get exhausted worrying about it or getting biopsies. So there's no right or wrong answer. But just some things to consider. And I know this was presented before, but just from a, patient-to-patient perspective, the risks and benefits of screening depend on your current and lifetime risk for cancer. Well, that would be great for all of us to take into account. And you saw the screenshot for the risk management from NCCN. And you may or may not remember that the first column was risk assessment. So if we're not all receiving a good assessment of our risk, and in my case, so, at every intake for every gynecologic exam I ever had, I was asked about my mother's side of the family and not really about my father's side of the family. And that's where my mutation came from. So we know that risk assessment isn't happening adequately for all patients. So, if that's that first column and that first decision point, then you're missing out on important information that you need to make an informed decision. I want to mention, because the USPSTF guidelines are actually tied to insurance coverage. And so that means that whatever the USPSTF guidelines say, those preventive services that get a letter grade of A or B should be covered with no out-of-pocket costs. And we'll talk a little bit more about that. Additionally, some states require coverage of guideline recommended screening MRI for high-risk women with no out-of-pocket cost too. It's not most states, but it's some states. Certainly not all women are receiving that clinical breast exam from a doctor. That was what prompted me to do that first deep palpation of my breast, because I had never had a clinical breast exam by the time I was 33. And, you know, it's great that we talk about breast awareness. Back in the day when I started FORCE, there was a lot of focus on breast self-exam. But regardless, whether we're talking about breast self-exam or breast awareness, women are not being informed about what that means. And I thought it was great that Dr. Beavers talked about what breast awareness means. So what are some things you can do? Know your risk for breast cancer. If you don't know, ask your doctor, ask for a referral to a genetic counselor, learn your risk, know your family history, and then understand the benefits and risks of screening, but also of not screening, because we hear a lot about the harms of overdiagnosis, but we don't always hear about the harms of not screening. So those are things that you should talk to with your healthcare professional, understand both sides, and then make a decision that's right for you. Consider a clinical trial. I'm going to tell you about one that is currently looking at risk-based screening that offers genetic testing within the clinical trial. Know your healthcare benefits, rights, and resources. So the Affordable Care Act has provisions in it that call for the coverage for people who have most health plans, not all health plans, but most health plans have to cover whatever the USPSTF guidelines recommend for preventive services with no out-of-pocket costs to you. Additionally, there may be state laws that offer even more coverage. And then the CDC has a national breast and cervical cancer early detection program that pays for mammograms and, in some states, high-risk screening for eligible people. Then consider your own priorities and preferences. Are you someone who is more averse to going through additional biopsies and finding out, or having additional screening and finding out that it was benign, or someone who's going to worry if you don't do it? And know your body. Ask your primary care provider for a clinical breast exam if you haven't had one, and instructions on what to look for. What does breast awareness look like in your own breast? So, you know, just a slide about this. If you don't know your risk, ask. And Jennifer gave a great presentation. I wanted to let you know about the National Society of Genetic Counselors. They have a Find a Genetic Counselor lookup tool, so you can do use the QR code to take you directly there. You can look for a genetic counselor in your area. Make sure you choose cancer genetics as the area of focus. And they also have a lookup tool that allows you to look for genetic counselors offering counseling via telehealth. Consider a clinical trial. So this is FORCE's website. We have what we call our research, search, and enroll tool, and this is a QR code that takes you directly there. We have mostly studies, prevention and treatment studies, that are enrolling people with inherited mutations, but we also have studies that are looking at identifying who may be at high risk. And I'm going to show you this one on the left, the Wisdom study. This is a nationwide large study looking at risk-based screening for women. And this is the listing on the FORCE website, but the Wisdom study also has their own great information. This is the QR code that can take you directly here. The genetic testing is part of the study. And then based on, or it can be, actually it's a complex study that I won't go into, but then your screening may be based on your genetic test results as well as other factors. Knowing your health benefits and rights. So the Affordable Care Act, as I mentioned, making sure that your health plan is included under the Affordable Care Act as offering preventive services, in which case you should be able to get your screening if you're eligible with no out-of-pocket cost to you. And then these are some of the states. FORCE has been working very closely with other groups, including Susan G. Komen, to try and pass state-by-state laws that cover either supplemental screening for people who have abnormal mammograms and or breast MRIs for high risk individuals, again, with no cost sharing, so no out-of-pocket cost to you. I don't know if this is all the states or if it's updated. You can go to the Force website to get more information, but these are some of the states that did pass these laws. And then there may be additional screening resources. I talked about the CDC's National Breast and Cervical Cancer Early Detection Program that does include funding for low-cost mammograms and/or breast MRIs for high-risk individuals. And this is the QR code that will take you to that website that has more information by state. Ask for clinical breast exam. And ask for instructions on what to look for in your own breasts. So what does breast awareness mean for you, so that, then if, like me, you find something, you can report it to your doctor and you know what you're looking for. Make sure you're looking for the most reliable online health information. Force actually has a resource called Spot the Boast that we use to help kind of walk people through what may be reliable and what may not be reliable health information, especially the media headlines. Sometimes they don't get the whole story, or they get the research wrong. And this is a fact-checking site that is talking about thermography and how it's not a substitute for mammogram. So this is a credible website. This is our Spot the Boast, just quick promo of it. And here's the QR code that kind of walks you through these kinds of decisions with regard to, is something reliable online health information or not? And here are some resources, and these have been compiled by all of us, all of the speakers. And there are many, many more outstanding resources out there for you. And I believe you guys all get a copy of these slides, so you should be able to access them. So with that, thank you so much. I'm going to invite the other speakers back on for Q&A.
Thank you. Thank you again to all of our presenters. The Q&A session will begin shortly, and you may now submit your questions to the presenters. I'm not sure. Maybe Terry, you want to take this? Why is BSE not recommended, and what can be the disadvantage?
Sure. So BSE, breast self-examination, it actually was studied in a very large study involving over 160,000 women. They were randomized based on the community they lived in. This was in China, pre-industrial revolution. And so none of the women routinely got mammograms in the pre-industrial revolution era. So some women were randomized to breast self-exam, and the other women were randomized to no breast self-exam. And it's not that they were told to not do it, it's just that it never came up. So what was shown is that the mortality rate was the same between the two groups, as was the stage, and the false positive rate was much higher in the screened group, the women who did breast self-exam. So we're not saying you can't do it. It's just we want women to be empowered however they feel they can best learn how to check their breast. And that may be by a breast self-examination. It may be some other way. So yeah.
Great, thank you. So we have a couple of questions kind of going back and forth with false negatives and false positives. So what are the major causes of false negatives? What types of breast cancers and or types of breasts are more likely to generate false negatives? That's one question.
Okay. So false negatives, that's when there is a cancer there, but the mammogram, if you're doing a screening mammography, doesn't see it. And of course, dense breast would be one type of breast that is more likely to generate a false negative. Lobular carcinomas, they are more likely to be missed on a mammogram. They don't tend to develop as a three-dimensional mass. Instead, they develop in a sheet of tumor cells. And so the mammogram is really just looking through a single layer of tumor cells, and it doesn't pick it up. So those are some examples: dense breast and lobular carcinomas.
Okay, thank you. And so, and this is a good point. Like, what is our like obsession over the harm of false positives from added screening? That any woman with personal experience with cancer treatment will agree that the potential harm from false positives is next to nothing in comparison with the potential benefits that more thorough screening can offer.
That's certainly NCCN's position. Is we feel that there is value in the benefits, even though annual does have more false positives. The U.S. Preventive Services Task Force is very harms adverse. And I'm not really exactly sure why they are so harms adverse, but that's their focus. And so whatever they can do to decrease the harms is what they would recommend.
And if I could,
Yes.
just from the patient perspective, as someone who was very fortunate to have a cancer, caught early. Well, I mean, it had already spread to my lymph nodes, but I do think that, again, all things being equal, if someone has hidden risk factors in their family, or they haven't had a adequate risk assessment done, then they're going to be more likely to be harmed by not having the screening than someone who doesn't have. Like, you don't know what you don't know, and so if you're high risk and you don't know it, then there is an increased chance that you're going to miss something by not screening. And I mean, not obviously, one person, and I come from a bit of a bias because our constituents are people with inherited mutations. But I think until we're better at assessing risk for everyone, there is a chance we're missing people who are high risk and they're not getting screening and they don't know it because we're worried that that additional screening will, cause them potential biopsies.
I see. Great. Thank you. I think too, it's just, there's fear. The mammogram's an annual. I mean, it is very distressing for a lot of people.
Yeah.
And so maybe we're not, or, maybe we have to change the tone somehow so that it's not something that's dreaded every year. It's just something that's just needs to be done. And, I mean, do you have any suggestions to maybe cope with the stress of having the mammogram and waiting for the results or the MRI or ultrasound results?
I'll let you
Well,
know
I
when I
think
figure it out. I have scan anxiety every time I need a scan now, you know.
Yeah, so it's okay. Yeah,
Sorry,
I
go ahead.
understand. It's like a fact of life. I understand.
and
So if a follow-up initial okay. Oh, if a follow-up after initial mammogram is needed, it is mammogram with ultrasound just as good as an MRI for a woman with heterogeneous dense breasts.
so that specific question has not been studied in a clinical trial, but the ultrasound study that I referenced in my talk also did a single round of MRI. And what they found was that MRI was more sensitive than ultrasound, but it did have a large number of false positives. One of probably the biggest issues, now I know that Sue had mentioned states that cover MRIs as part of their screening. At least in Texas, it is not currently covered without out-of-pocket costs. So that means they're subject to deductible and copay. And if you have a high deductible, say $5,000, well, you may get hit for the whole cost of the MRI.
Yes, definitely.
One
It's a
of
real problem.
the advantages is of ultrasound is it's easy to target an ultrasound. I mean a biopsy by ultrasound, easier than MRI. We can target a biopsy through MRI, but it's more complicated. So that's kind of why we go there first.
How young is young for a cancer diagnosis to be considered for genetic testing?
Yeah, I love this question. It depends on the cancer type, and it also is dependent upon your country. And so if we think about, and that's partly due to population demographics, right? And so in the United States, the average age of breast cancer diagnosis is around 62, 63. And so when I'm seeing someone less than 50 and in their 40s or 30s or 20s, then I'm putting them in the young category. But I think it's important to note that it's not just one feature that is making that determination. Do we think this family has inherited disease? And so it's putting it in the entire context. If you take a group of young people who are young women diagnosed with breast cancer, and you look at nothing more than age, they are more likely than if you were to take a group of women diagnosed at an older age. But that doesn't mean that if you're diagnosed with breast cancer at age 70, that you don't have an inherited predisposition that caused that. So it's again, looking not only at age, but a variety of other factors.
Great, thank you. So a couple more questions about some genetic testing and genetics. Can the genetic tests presented predict risk of recurrence for a breast cancer survivor?
Yes, and I think this is a very common question and an appropriate concern for people who have been diagnosed with a cancer is, what is my likelihood of a recurrence? And we spend, trying to help come to a shared understanding of the difference between a recurrence, that original cancer returning, versus a second primary, whether it be a second primary breast cancer or a different cancer type. And so when we're talking about genetic testing at this time, it's really not referring to likelihood of recurrence. It's giving us information as to if we ignore the fact that that person's had a cancer, what is the likelihood in your lifetime that you will be diagnosed with a cancer? Certain cancers, depending on the gene. And for some of the genes, we have better data than others of the likelihood of second primary cancers.
Does finding a genetic mutation entail going through some treatments, or is it enough to opt for surveillance only?
Oh, wonderful question. And I think that brings into autonomy in medical decision making. Certainly, if you look at many of the guidelines, and Sue can weigh in as well on this, many of the guidelines for predisposition syndromes that are associated with breast and other cancer risk, you'll see the options of intensified surveillance versus risk-reducing mastectomy. And again, presenting that as a choice is very appropriate in that setting. In other cancer risks, so for example, Sue brought up BRCA2 and BRCA1, we know that there's a high risk for those women to develop an ovarian cancer in their lifetime. And because we don't have excellent screening for ovarian cancer, like we do for breast cancer. It's often presented as let's pursue risk-reducing surgery because we don't have that screening option.
And if I may just add one other thing too, because we hear that fear of feeling like you have to have surgery if you test positive as a reason why people don't want to have testing. And so it is about body autonomy. I love that. It's just such a great term. And it is your choice. And there are options. And there are actually, clinical trials looking at other ways to detect or prevent cancers. The other thing that I did want to say, and I saw a question in the chat before in the Q&A about how often are the guidelines updated. And I'm very fortunate to sit as an advocate on the hereditary cancer, breast, ovarian, and pancreatic panel. And those are updated every year. So, and the other thing I want to point out is there are genes that, other genes beyond BRCA1 and 2 that increase the risk for breast and other cancers. And again, it goes back to the recommended interventions really depend on your level of risk and then, the choices that you make. So they're not all as high as BRCA1 and 2. And for some, the guidelines recommend considering surgery versus, or considering MRI. So it really depends on what your results are and, working with a genetic counselor or another expert to understand what your risk is.
Thank you. So I'm reading, there are quite a few questions coming through, so we're going to get to as many as we can, but so I'm not going to read all of this, but I am reading about someone diagnosed with a second breast cancer after a double mastectomy. And so the question is like how to talk to your care team, but I'm also curious how screening is affected because in this case, breast tissue was left behind. So how do you know? Because you don't typically screen after mastectomy. So what is the screening? How do you handle follow-up? And how do you suggest, I guess in this situation, how do you talk to your care team if you're asking questions and you feel like you're not getting answers or you want more questions about screening? What are your suggestions? What should you do?
So I'm happy to take the part about talking with your care team, although I don't know if I have answers. But with regard to screening after surgery, after mastectomy, that really varies. There isn't a lot out there. The risks are pretty low still, but they happen and we see it, especially at force. And so, that ends up being oftentimes based on your surgeon's recommendation. With regard to talking to your healthcare professional, we talk a lot about empowering patients and having that conversation. That's not always easy. And so I might not have answers, but I can definitely commiserate because it seems to me, especially since the pandemic, there's a very exhausted health system out there. And so it's not so easy as always to find another doctor. I'd say go with a list of questions. Use your patient portal to ask questions, through your patient portal. Doing it in writing, it kind of gives you a trail and allows you to follow up and make sure that everything that you're asking is being considered. And if all of those things don't help and you have a healthcare professional that is not listening to you, then really, if you have that luxury of options for other healthcare professionals, then you may need to find someone else.
Terry, did you have anything to add?
Yeah. So I think it's a good idea, first off, to go in with a written list of questions. I like to get that list of questions ahead of time. So if the patient gives it to the nurse, so that I can start to frame my thoughts. And I also know how many questions there are. It's not just, oh my gosh, when's she going to end? kind of thing. I know what the end is, and I may say, you got a lot of good questions. I don't know that we're going to get to all of them today, but let's start off with what I think are the most important and tackle it that way.
Okay, great, thanks. So if a woman has a mammogram and is identified as having dense breast, what is the screening recommendation?
So we recommend on the NCCN guideline that she be counseled about the benefits and harms of supplemental screening with MRI and ultrasound, not both, one or the other. MRI, again, is a much more expensive test, and if it's not covered with no cost sharing, she may carry a fairly sizable cost to get that. Ultrasound is easier to get authorized. Not all insurance plans will approve MRI for dense breast. So those are some of the variables I think about.
And is there any research about the percentage of women that actually complete annual or regular screenings?
Yeah, there is. I don't know that data off the top of my head, but it actually is quite good. Many women do pursue annual screening.
And there is a question about how mammography is the sensitivity of mammography to flat breasts.
I guess they're saying thin breast, maybe.
Maybe small breasts.
Yeah. That may help with density because they're thinner, so it's less tissue that it's having to look through.
Okay. So if you know there's a family history of cancer in your family, but the family has not documented what types of cancer or who had it because it was culturally not discussed, how can you bring up genetic counseling with your doctor? Or, like we said, maybe you don't know your complete family history. Not everyone knows their family history. They don't know the details. So yeah, it can be embarrassing to ask your doctor when you don't have all of the information.
I would actually encourage that person not to start with your doctor, but to start with your family. And at least in the United States, let's say someone has passed, their death certificate is a publicly available record. And so it's possible if that person passed from that particular type of cancer, that would be listed on the death certificate. So ideally, we're having conversations with our families and family members about our medical health history, and we're trying to just make that part of the family story. But I agree, for many families, for whatever reason, that may not be the case. And so it's very hard to assess a family history of cancers when we don't know the type or ages at diagnosis. Potentially there's exposure. So again, if you have a strong family history of primary lung cancer, but all of those family members had a long-standing history of smoking, that may be a much more important risk factor than the fact that it's multiple family members. So it is a challenge, and I hope as younger people and all of us today moving forward with our own families, that we can make our family medical history just part of our normal family story, and telling all those beautiful stories about our family, which also include part of our medical history.
Thank you. How common is a pre-menopausal woman less than 35 years with breast cancer having both BCRA1 and BCRA2 mutation? What preventive measures screening should be done to detect cancer in the other breast, ovary, or other organs?
And I don't know if Sue has specific data. I don't have specific data. I've seen a couple women who have a mutation in both BRCA1 and BRCA2. And if you think about what that test result means, is that particular family has 2 inherited cancer predisposition syndromes. And in the context of which I've seen that are women who are of Ashkenazi Jewish ancestry, where we have an increased frequency of at least certain mutations in the BRCA1 and 2 mutations. So just from a population standpoint, I've seen that. But in most families, whether it's BRCA1 or 2 or whatever cancer predisposition you're talking about, you're going to have 1 cancer predisposition in the family, not 2. And we all have exceptions to that. And I can see a lot of important comments coming from people who might have been missed based upon their family history. But it's typically you would see 1 cancer predisposition syndrome.
Interesting. Okay. Do you recommend annual breast exams for a woman aged over 85 who had breast cancer 15 years ago?
I think that really needs to be individualized. You know, how healthy is she? If we find a breast cancer, what are we going to do with it? Many surgeons are very reluctant to take a 85-plus-year-old woman to the operating room. When you sedate someone at that age, it not uncommonly can affect cognition. So, you know, if that family member were to wake up and you've taken care of the cancer, but now they don't remember things, was it worth it? And these are things that we need to think about before we do the breast exam in the first place.
Great, thank you. So we are out of time, and I think we've covered most of the questions. We do apologize if we didn't get to all of them. But thank you everyone for attending. We appreciate those from around the world that have attended, and we appreciate your questions. The NCCN Foundation would like to also thank the corporate supporters of this webinar. Thank you again, Terry, Jen, and Sue. Thank you, everyone.
Take care.
Thanks, everyone.
Bye.
Take care.